Thank you. A very good afternoon, starting with our instruction course on Retina Bootcamp with the purpose of showing the very illustrative cases and giving some key messages from the august panelists that we have here. So all the speakers are going to show you very good illustrative cases, which will be very useful for comprehensive ophthalmologists as well as retina specialists. We are honored to have a keynote speaker before we start our instruction course by Dr. George Rocha, and it's my pleasure to introduce him. He's going to speak on OCT biomarkers for diabetic macular edema. Over to you, Dr. Rocha. You can share the screen.
Can you see my slides?
Absolutely. Everything is fine. All set.
Thank you. Hello, everyone. I'm very happy to be here with you in the 79 All India Ophthalmology Conference. I have no disclosure concerning this topic. And I'd like to say that I'm very happy to join you in this very distinguished Congress. And I think India and Brazil has a lot to share in science and friendship. Diabetes is a pandemic across the globe. We have more than 400 million persons with diabetes, and this can cause severe vision loss with vitreal hemorrhage, retinal detachment, and also macular edema. And today we're going to talk about the biomarkers. And biomarkers is a characteristic that's objectively measured and evaluated as an indicator of normal biological process, pathological process, or pharmacological response to a therapeutic intervention. And in diabetic, we have several biomarkers: functional, inflammation, image, and genetic. And today we're going to focus on image biomarkers. And the biomarker can be progression biomarker or predictors biomarkers. And the first biomarkers is the fundus photography. And we learn from ETDRS that retinal detachment and retinal neovascularization are predictor of very bad visual acuity. And also we have nowadays ultra wide field fluorescein angiography. And this 200 degrees fundus angiography can predict, can access peripheral retina ischemia. And this can tell you that we have more than 3 times odds to progress to macular edema or severe retina diabetic. Also, we can talk about autofluorescence. That's when the patient has diabetic macular edema, we have increased the autofluorescence. The oxidation stress can increase the lipofuscin inside the cells and can cause increase in the autofluorescence. But now we can talk about OCT. OCT has several biomarkers like retina thickness, sponge-like diffuse retina thickness, presence of height of intraretinal cyst, surround retina detachment, tractional diabetic macular edema, disorganization of retina in a layer, integrity of ellipsoid, interdigitation, or external limitant membrane, a hyperreflective retina foci. And the sponge-like diffuse retina thickness is one of the most common retina macular edema and respond well to photocoagulation or anti-VEGF, as well steroids. The other one that's not so frequent, like the serous retinal detachment, is presenting 10 to 15% of macular edema and only respond to therapeutic steroid or VGF, anti-VGF that's driving more by inflammation, interleukin 6. And also cystoid macular edema. Cystoid macular edema is a very bad prognosis because we sometimes have such a large cyst that can destroy photoreceptors and they can cause loss of vision and can respond only a therapeutic treatment. And the last ones, macular traction. Macular traction, the treatment is surgery and many times has very bad prognosis. Now, to resume, we can show you that sponge-like diffuse retina sickness can respond to laser or treatment, or cystoid macular edema pharmacological, serous retinal detachment also pharmacological, and tractional vitrectomy. And now, predictive biomarkers. The first one is the disorganization of retina inner layer. That is the loss of the inner layer of the retina in the 1 millimeter center in the fovea. And if you have lost all these layers, we can predict that the visual acuity is going to be worse in this patient. Another very good prediction of vision is the external lines on OCT, like external limiting membrane, ellipsoid zone, and RPE interdigitation. They can show us the photoreceptor. And these lines, if you are able to see, they're going to predict very good vision. But if you lost one of these three lines, can predict that the visual acuity will be very worse. Like this case, the patient has large cyst, loss of all the lines of external retina, and drill. They could not improve any vision after treatment. And now we're going to talk about hyperreflective retina foci, the small dot less than 30 microns that has absence of black shadowing, and they are present most in inner retina, but can see at outer retina as well. And mostly is from microglia cells. And this paper can show you that when you are going for severity of diabetic retinopathy, we can have the improve the numbers of these hyperreflective foci. And these hyperreflective foci can respond well to steroids or anti-VEGF, but this paper has shown us that they respond much better to steroids, and they can say that they are mostly driven by inflammation. All these biomarkers can combine, and we can have the drill, we can have the large cyst, you can have the hyperreflective foci or loss of the ellipsoid line. And all this can predict that the patients, even with the best treatment, can go with very poor vision. Now we can say some word about OCTA. OCTA can help us to assess the macular vascularization, all the plexus of macula, and we can understand about the vascular density or avascular zone or fractal dimension analysis of the vessels. The avascular zone, we can see the contour, the vessel caliber, the vessel density. The vascular zone enlargement can be very well correlated with worse diabetic retinopathy severity. Now you can see this contour that you can lost, and we can, when the foveal vascular zone as a circularity are lost, we can say that are progression of diabetic severity. And the vascular density, the superficial or deep capillary plexus, they all predict that we're gonna worse visual acuity and diabetic severity. The principle is the deep capillary plexus. The 3D perfusion also is correlate with bad visual acuity. Here we can correlate that when you lost the deep capillary plexus, we can lose the anti-VEGF. In conclusion, wide field fluorescein angiography allows you to assess the peripheral vascular abnormalities. OCT biomarkers can predict prognosis and help tailor treatment. And OCTA may help appreciate macular retina vascularity and predict treatment prognosis.
It's a meeting going on. I have to speak in a while.
Thank you very much.
Thank you very much, Dr. Osha, for a very clear understanding of the biomarkers. But we all understand that even if we see the biomarkers, we do tend to treat these patients, and many of us have many non-responding patients at our hand. So I would like to invite our next speaker, none other than Professor Atul Kumar, who doesn't need any introduction in AIOS, who will be talking about non-responding diabetic macular edema and what next. We can take up the discussion after his talk. Thank you, sir.
You can see the slide.
Yeah. The slides are visible. We just need slideshow.
Yeah.
This one, yeah. So next to animations.
सर नीचे आपको कब बना होगा एक नीचे लास्ट कॉर्नर यस यस सर नीचे कॉर्नर में कब बना हुआ है सर सर आपके लेफ्ट साइड हाँ ये रहा कब बना हुआ कब यस
just towards the left no this one
सर कब बना हुआ इस पे क्लिक कीजिए कब पे
I'm looking for the cup here.
Sir, this in last corner, in right hand side.
Animations.
There is screen for right hand side.
Sir,
another this one, next one, sir.
Sir, just move.
First one.
Sir, move left towards this.
Sir, ये कप जो बना हुआ है बुक्स के साथ.
Sir, जहाँ पे ये माइनस का साइन है उससे just left नीचे ही जहाँ प्लस
माइनस का साइन है.
वहाँ उसके साथ ही सर.
सर आप ऊपर से कर लीजिए इसके एनिमेशंस जैसे होम या यू कैन डू दिस एंटर फुल स्क्रीन सर उसके साथ स्लाइड शो है या डिजाइन ट्रांजिशंस एनिमेशंस एंड देन स्लाइड शो जस्ट क्लिक या दैट्स इट सर सो प्ले फ्रॉम स्टार्ट फर्स्ट वाला
Is it fine?
No sir. This is a wrong, sir.
Okay, sir, we'll go on.
Okay, I'm going to talk on non-responding DME and what's next for that. Now, you got to understand what is a non-responder in DME. So, less than 5 letters improvement in visual acuity or less than 10% improvement in the central macular thickness or the central subfield thickness after 4 to 5 successive monthly injections of anti-VEGF is actually what is sort of defined as the non-responder, because less than 5% improvement in visual acuity or less than 10% improvement in the central macular thickness. So that's approximately the definition, which is very important to know. And it's the drcr.net which actually defined this difficult definition. So the protocol I and the protocol T which were two important DRCR.net studies besides others, showed that nearly 40% eyes had a problem, and there was persisting edema in 23% eyes in the protocol T group in the Rise and Ride study. The protocol I showed persisting edema in about 40% of the eyes. And the protocol, the Rise and Ride showed that there was a persisting edema in about 23% eyes after two to 3 years. So you have to understand that both the important studies showed that there was a persisting macular edema. The causes of non-responding edema can be poor glycemic control, that is systemic factors, nephropathy, elevated serum lipids, hypertension. They're all important factors. Extensive hard X-ray, especially clustered towards the fovea, inadequate laser in PDR have all been contributed to the non-responding edema, because sometimes diabetic retinopathy actually goes up to the periphery. So if you don't get laser up to the periphery because the ischemic areas may still stay, that can produce VEGF, that causes VEGF production in the periphery, which causes macular edema. Tractional DME is another important condition in which you have to identify on OCT, and if you do pick up some, you can do the dynamic focus and DF, which is there in some of the source OCTs like the top cone. So you can see the vitreoretinal interface. If there's a tractional element, that may be a cause of the non-responding DME. And so is the case for vitreomacular traction, thick taut posterior hyaloid, which is so commonly seen. The hyaloid tends to thicken and becomes opacified, and this pulls on the macula and causes unrelenting edema. And I just mentioned that wide field angiography is of great help, and it sometimes helps you to pick up peripheral retinal ischemia, which causes VEGF release and release and subsequent indirect macular edema. So Accord study was an important study, which actually about 7, 8, 10 years back told us that glycemic control and dyslipidemia control can forestall progression of DR in patients with type 2 diabetes, and it treats non-responding edema. So this is a systemic factors. The study which actually contributed, and also the published study told us that it is important to have a good control to treat conditions of non-responding edema, because sometimes these patients, like in the COVID period, they went out of control, many of our patients, and it's happened all over India, probably all over the world, when patients didn't have their diabetic control in place when the COVID was there, and they just stayed inside without realizing that, without any physical exercise and without getting their checkups. So lipid, renal functions, anemia, all that can also contribute. So neurodegeneration is a very important condition for non-responding DME, and suddenly you get this outer retinal tubulation, which is actually the degenerated photoreceptor outer segments. And even as Dr. George Grosha also mentioned, the hyperreflective foci and the loss of the inner outer segments, inner segmentation of the central 1 millimeter. So all these biomarkers, especially presence of ORT is a significant pointer towards neurodegeneration. So diabetic retinopathy is not only a vascular disease or of the retinal microangiopathy or causing microangiopathy, it is also neurodegenerative disease. So you have a patient who's got recalcitrant or non-responding DME. He's got a little ORT over here, and he's got multiple HRF. So you give the injection and still he doesn't improve. So this is a non-responding DME. So ultra wide field angiography really helps you to pick up peripheral lesions which have ischemia, and that can be lasered. And laser has an important role in non-responding DME, because if there's a peripheral ischemia. There's an ongoing DRCR.net realized the importance of wide field angiography, and they brought out a trial, the protocol AA, which is an ongoing trial, and it's comparing the ultra wide field fundus imaging to the ETDRS7 standard fields, imaging for the assessment of DR and prediction rates of worsening of DR. So this is a case which is showing a 49-year-old male. A1C was 8.6, uncontrolled, DM 15 years. VDR showing extent of laser done, augmentation required. So these kind of patients not only develop DME but also traction, elevated retina. So you can see the lasers being done here, but because the edema, if you do the fluorescein, actually the fluorescein tells you the ischemia and the unlasered retina. So when the hemorrhage cleared up, this is the extent of laser which needs to be done. And the wide field actually tells you how far periphery you have to go. So it's important to find the cause for the poor response for non-responders. Individualize the treatment for each patient. It's important that you can't have a blanket treatment, same for each patient. And utilize combination therapy wherever possible. So targeted retinal photocoagulation has a major role, and wide field angiography tells us that there's an increased 3.75 times increased odds of having DME compared with eyes without non-perfusion. So if you've got retinal non-perfusion on wide field angiography, it's a 3.758 times increased chance of having DME. Because once you treat the peripheral laser, with peripheral laser, you have decreased requirements of VEGF. Ultra wide field, we also presented this in the RO, and one of our senior residents had gone and presented the poster, and it's ultra wide field angiography. And we had done this as a project, and we did targeted laser photocoagulation of the eyes of those portions of the retina which were ischemic. It's actually the healthy retina is not to be treated. So the concept is now that you don't treat the healthy retina, cause dark adaptation problems and color vision problems and accommodation problems, but rather treat only the ischemic, unhealthy, or the diseased retina. So this is, we've targeted the ischemic areas only with the Pascal laser, and the Pascal laser really helps to treat only, you get multiple spot patterns and pattern scan laser, and you can treat the ischemic areas only. There's another treatment which is there for non-responders, which is after anti-VEGFs, after steroids, after control of diabetes, after peripheral laser. You also have in your hand another option, which is subthreshold micropulse laser. It's got a partial, probably some role, and it may be an adjunct to the standard of care, which is already there. So it's not going to be a primary treatment. It may have a stabilizing effect on the visual acuity. More work needs to be done. The role of steroids is very important. It's as a combination therapy, or even as a primary therapy, or a second tier treatment. Patients, especially who are pseudophakic and not suffering from glaucoma, are ideal patients. So dexamethasone implants are there, and we've also injected many of these. I've done a lot of these non-responders with Dexa implant with very satisfactory results. The role of PP is always there, and because of which is the last I would say the last option which you will have in the various treatment modalities you have with you, and it removes the inflammatory mediators. It probably increases the oxygenation to the macula, but it's got a limited role because eyelid peeling may cause more damage also. So these are the kind of cases which can be taken up with a vitreomacular traction. So if there's a vitreomacular traction, I'll just show you 2 seconds time. My time is up, so I'm just finishing in 2 seconds, Professor Vishali. So this is just to peel off the central hyaloid. Thank you.
Thank you, sir. From both the talks, we got very clear message that first is you rule out the tractional variety. If that is the case, straight away take them up for surgery. If it's a non-tractional variety, look for the biomarkers that were so elegantly described by Dr. Georgie, and then Dr. Atul, drill, hyperreflective, serous detachments. If you have one of those biomarkers, just talk to your patient and decide about injecting. Also look at the wide field to look for areas of capillary non-perfusion which may need to be addressed. For lack of time, we will take up the questions from the audience towards the end of the session. And with this, it's my pleasure to introduce Dr. Deeksha, Associate Professor in the Retina Division of PGI. She's going to tell us how to approach a case of thickened choroid, something which has become of late, a difficult thing for many of our youngsters because everybody is talking about Paki versus non-Paki. Over to you, Deeksha.
Good afternoon, and thank you, Vishali ma'am. Good afternoon to Atul sir, Rima ma'am, and all my co-panelists. I'll be talking about thick choroid and what we need to know about pachychoroid. So pachychoroid group of diseases are a set of disorders that occur secondary to an abnormally thick outer choroid. And it is now considered to be a spectrum, and it involves the following clinical entities. It starts from pachychoroid pigment epitheliopathy to central serous choroidopathy, pachychoroid neovasculopathy, polypoidal choroidal vasculopathy, also now renamed as the aneurysmal type 1 choroidal neovascular membrane peripapillary pachychoroid spectrum, and focal choroidal excavations. Let me start by giving you an example. I'll be describing all the salient features because the underlying morphological changes are similar with this representative case. A 24-year-old male software consultant by occupation presents with a 3-week history of distortion and diminution of vision in the left eye and has history of using steroids for acne for the past 2 months. He's a non-smoker, non-alcoholic. On clinical examination of the left eye, we see what appears to be a fibrin, just temporal to the macula. The right eye was normal, and we order a swept source OCT. Now we have to look carefully at what the OCT is showing. Here we can see where the arrow is, we can see a serous pigment epithelial detachment. We could also pick a micro rip in this case. The fibrin area is correspondingly on the OCT is showing hyperreflectivity in the subretinal space, and there is a serous detachment, shallow serous detachment. What we have to look now is at the choroid. We look at the white line, that is the choroidal scleral junction. Just below that, below the pigment epithelial detachment, we see that there is an increased hyporeflective lumina, which is occupying almost the entire thickness of the retina. If we look closely and measure the subfoveal choroidal thickness measured from the Brooks membrane to the choroidal scleral junction is increased 479, and the hyporeflective lumina are occupying the entire thickness of the retina, and also the inner choroidal layers are thinned out or attenuated. The right eye, which does not have any clinical signs, also shows an increased subfoveal choroidal thickness of 498 microns. But look carefully, the inner choroidal structure appears to be well preserved. So the first important point for pachychoroid diagnosis is an increase in choroidal thickness measured in an absolute value of more than 300 microns measured subfoveally, or an extrafoveal focus of increased choroidal thickness exceeding the subfoveal thickness by 50 microns, or even an area of maximal choroidal thickness is considered significant if it correlates spatially with the distribution of the pachy vessels and with the disease focus. The second key feature, and probably very important feature, is the attenuation of the inner choroid. You have to keep my OCTs in mind. Focal or diffuse attenuation of the choriocapillaries and the intermediate Sattler's layer in the area involving the abnormally dilated Haller's layer vessels is what is classified as attenuation. This feature helps classify the patient as having either just a simply pachychoroid, where we do not see any attenuation, versus pachychoroid disease, where we see attenuation of the inner choroid. Moving on, fluorescein angiography was and we see the characteristic features of an expanding dot hyperfluorescence in this patient, and without any associated RP abnormalities. So this patient was diagnosed as an acute CSC, but look what the other eye shows no leaks, just a focal RPE window defect, but the ICG gives a lot more perspective. So this is the right eye, which was normal. What we are seeing that the choroidal vessels in at least 3 quadrants are appearing more brighter, they are increased in caliber, and there is associated fuzziness in the posterior pole. If we look carefully at these dilated and prominent choroidal vessels, we notice, if you look at where I have marked, that these tend to terminate abruptly, as against those where they are not dilated, where they have tapering ends towards the posterior pole. The ICG of the left eye also, if you compare the temporal versus the nasal half, we see these prominent dilated choroidal vessels associated with increased choroidal vascular permeability, as is noticed in the posterior pole. And this leak lately corresponds to the leak on the FA. So the third important characteristics is identifying the pachy vessels. I have told you how we identify pachy vessels and choroidal vascular hyperpermeability in the mid to late phase of the ICG, even seen in eyes without the disease, and can persist even after resolution of the disease. This is associated with increased extravasation of fluid and lipoprotein-bound ICGA from the choriocapillaries or the vessels into the stroma. Associated choroidal filling defects, delayed arterial filling, and focal or punctate areas of possible choroidal ischemia may be associated. Now, with this background, I will come just briefly about the other entities. Pachychoroid pigment epithelial epitheliopathy is considered a first form of CSC. You have focal RPE abnormalities seen on the autofluorescence, irregular drusenoid RPE elevations known as the pachydrusen, with absence of the soft drusen and features of pachychoroid. No subretinal fluid is present and patient is generally symptomatic. Pachychoroid neovasculopathy is a type 1 neovascularization overlying pachychoroid disease. You will see shallow irregular RPE detachments. You could see a double layer sign, but there is absent or minimal soft drusen and the age is generally younger. OCTA helps to shows us the tangle network of increased flow of vessels in this category. PCV, we know it is characterized by polyps and branching vascular networks. It has now been renamed as aneurysmal type 1 neovascularization because we know these polyps are vascular in nature and have the potential to rupture and bleed, and they are not epithelial, and because multimodal imaging has consistently shown the pathology lies between the RPE and the inner collagenous layer of the Bruch's membrane. That is why type 1. This is one of our patients which has features suggestive of PCV, absent drusens. We see exudation, hemorrhage, and this is the OCT. It shows us the pachyvessels, the increased choroidal thickness, double layer sign, and attenuation of the choriocapillaries or the inner choroid. ICG confirms the pachyvessels as well as the polyps. Now, one thing for PCV, we have to remember that we may have two subsets of PCV. One that is associated with normal choroidal thickness and the other with an increased choroidal thickness. Now, in over 90% of both the groups, pachyvessels have been observed below the presumed origin of the BVN, feeding the aneurysms, occupying nearly full thickness of the choroid, and also demonstrated overlying attenuation of the inner choroidal rays. Therefore, both these categories are included in the pachychoroid spectrum. Peripapillary pachychoroid, in this, the pachychoroid features preferentially around the optic nerve and the nasal macula. Importantly, we also see choroidal folds, shorter axial lengths, and hyperopes, and therefore this comes as one of the DDs with uveal effusion syndromes, but there are no choroidal detachments. And it has also been implicated, forming like a compartment syndrome around the optic disc. And lastly, we have focal choroidal excavations. Both the conforming and non-conforming type pachychoroid features have been described in eyes with focal choroidal excavation. Thank you.
Thank you, Diksha. That was a very clear message. Now, I have two questions for you from the audience. And these are the questions everybody has in mind. It's a patient of CSC or PCV. How would it make a difference to your life and to patient's life whether these are associated with pachychoroid or without pachychoroid? You're muted, Diksha. You're muted.
Ma'am, as far as the management principles may be concerned, the management principles may not differ, but for example, in a patient of CSC, but there are patients where sometimes for example, this was an acute CSC, but there are some patients where we have always had those dilemmas because we were seeing widespread RPE alterations. We thought, we kept labeling them as CSC, chronic CSC. However, they belong to the spectrum of PPE or the pachychoroid neovasculopathy spectrum. And in today's era, some of these patients we were not treating, but now with the advent of anti-VEGF therapy, some of these patients are identified better, and then you can start or initiate treatment. As far as systemic therapy is concerned, if you're seeing such choroidal hyperpermeability, well, we can give a trial of those systemic agents. It may help, may not help, such as spironolactone, mineralocorticoids, may or may not help. But if you are seeing such features, maybe there may be a subset of CSC patients with pachychoroid and a subset without. So the subset which has these features, increased choroidal hyperpermeability, maybe we could try giving them, because we were not really looking at all these features earlier.
And my question to Dr. Atul Kumar, sir, do you always do ICG, confirm pachychoroid?
No, I don't. I often resort to OCTA.
OCTA.
If the CSC, chronic CSC, I always get a OCTA done. And if the OCTA shows some new vessels, I like to give an anti-VEGF.
Pachychoroid?
Pachychoroid, I would just follow up. I just follow up because pachychoroid by itself may be there in so many diseases, and I just let it be. But if there is a presence of a new vessels, only then I'll treat. So ICG is not warranting every
Okay, thank you, sir.
situation.
I agree. So with this, I think I'm switching my topic with Dr. Rima Bansal because she has to go for another talk. So I would like to invite Dr. Rima Bansal, who is additional professor with us in the services of uvea and vitreoretina. And Dr. Rima will be talking about approaching a lesion in the choroid. Over to you, Rima.
Thank you, ma'am, for giving me a chance to speak in your course, and respected Atul sir and my co-panelists.
Recording what?
I'll be talking on approaching a lesion in the choroid. So let's have this case scenario of the first case where the patient presents. The figure on the top, you have a patient presenting with acute loss of vision in the left eye. And you have another patient presenting with similar complaints, acute loss of vision since almost 2 weeks in the panel below. So these are left eyes of two different patients, and you're seeing some solitary lesions in the posterior pole. Now, when we look at the signs of inflammation which are present, like subretinal fluid, and there is a lot of vitritis, and there is some kind of vascularization in the top photograph. And the first thing that we do is a non-invasive imaging, and this is what we do, and we do an OCT. And on the top photograph, we see that there is subretinal fluid collection along with some subretinal fibrinous fluid. And there is bumping of the RPE, and there is obviously a mass lesion in the choroid, which is pushing the RP complex and the neuroretina up. In contrast, the lesion in the lower panel, you see the OCT, there is all the hyperreflectivity is limited to the retinal layers, and you have the entire inner retina and the outer retina probably affected by this. So what we get the information from just the OCT is that the choroid in the second patient is not really involved. And this gives us a clue that we are dealing with a choroidal lesion predominantly in the top panel, and we're dealing with a retinal lesion in the lower panel. So fluorescein is done to confirm our differential diagnosis. And here we see that choroidal lesion, typically there is hypo to hyperfluorescence along with pooling of the dye because of the collection in the subretinal space. And a retinal lesion or a retinitis begins with a hyperfluorescence in the early phases, which goes on increasing in the late phase. A second case where we have a patient presenting with not this time an acute loss of vision, it's a progressive loss of vision, chronic, ongoing for a few months. And when we look at the clinical examination, we don't see any signs of inflammation like fluid or vitreous cells or something like that. So here also, we can clearly see that there is something happening at the level of outer retina or choroid. So how we check is that we again do an OCT, and we find that there is a collection of subretinal lesion in the fovea, and you see some ripping of the RPE. So when we go back to the patient and we ask relevant history, we get to know that the patient is using steroid cream for a year for some skin lesions. Also is a known case of anxiety and depression. And when we do the autofluorescence, it almost completely gives us the diagnosis, and we have the gravitating pattern of the fluid in the left eye, and very classical of chronic central serous chorioretinopathy. The right eye is normal. So we do an FFA only to confirm, and there is this ink blot sign confirming the diagnosis of CSC. So this lesion, which just looked innocuous, causing a progressive chronic loss of vision, we just stopped the steroids, we observed the patient, and after 3 months, you see the entire lesion is gone and the patient gets back 6/6 visual acuity. So this is the OCT that shows completely normalization of the retinal layers at the end. Now we have a third scenario where we have a young girl presenting with decreased vision for almost 2 months going on. And now when we carefully look at this, what's happening in the macula or in the fundus of the right eye, we see a large lesion extending from the macula going beyond the superior upper temporal arcades. And we see some hyperpigmented part of the lesion. We also see a hypopigmented part of the lesion. And we also see some hemorrhage. Now, what are we dealing with? We do a swept source OCT, And we have multiple findings on this. You can see the horizontal lamellar lines, which represent the bone lamellae. We see an intense hyperreflectivity on the OCT. We also see the hyperreflective horizontal lines, which are known as cement lines. We see vascular channels. We see subretinal fluid here. And when we do an OCT angio, we see a neovascular complex here in the outer retina. Now this, when we go back, all these findings in the OCT and OCT angio, I would say rather OCT, take us to do an ultrasound rather than going to the fluorescein angiography or ICG. And the ultrasound shows that there is a choroidal osteoma, and CNVM we could see on the OCT. So we confirm, we do a combined fluorescein and ICG, and we confirm that there is osteoma with a choroidal neovascular membrane. So the key points of approaching a patient with a choroidal lesion is, of course, history, the type of complaints, the chronicity of the problem, and clinical clues and signs of inflammation or whatever clues we get. Multimodal imaging, of course, helps us. It's just that we need to choose the right imaging modality, beginning with the non-invasive like OCT and autofluorescence. OCTA gives us clue about many of the findings like CNV, and ultrasound, unless we have a strong suspicion, and then confirm the lesions with fluorescein and ICG angiography. Thank you very much.
Thank you, Rima. That was very crisp and clear message to all of us as to how to approach a patient with choroidal lesion. Dr. George Rocha, you are with us. So do you have any experience from your part of the continent as to would you do anything different?
No, I love the presentation, very clear. In Brazil, we have a lot of toxoplasmosis, and the multimodal image helps a lot to treat these patients. And I think in India, you have the same. You have a lot of toxoplasmosis, you have tuberculosis, and all this kind of image helps a lot to define the diagnosis and helps the treatment.
Thank you. Yeah, we do see toxoplasmosis, but not as common as we actually see tuberculosis, which is much more common. And with this, I would invite Mohit to answer the next question, Mohit. For Dr. Rima showed beautiful pictures of osteoma with an underlying new vessels. Like, what would be the clinical clues for you to say this is an osteoma, or is it a hemangioma, or a tuberculoma? Because we are doing this course for comprehensive ophthalmologists.
Absolutely, ma'am. I think those three are the three common differentials of choroidal masses, benign ones that we do tend to see. I think with most garden variety choroidal osteomas, which will be the least common incidence wise out of the three that we're talking about, is the appearance that a lot of people have in their mind that it would be white looking with vessels on top. It need not be true that it's white looking. In fact, it very seldom is. It mimics, it looks red, it looks orangish red, it looks a lot like a hemangioma. At the end of it, I think it's very important to the ultrasound characteristics will be the differentiating factor. Once a choroidal mass lesion which is non-infective, a choroidal granuloma is a clinical diagnosis, of course backed by other investigations, but to differentiate a choroidal hemangioma from an osteoma, I think the ultrasound is the clincher, because even in massively decalcified osteomas, the ultrasound will show considerably high spikes in whichever area there is some calcium left. So I would say, ma'am, the ultrasound, as far as the choroidal granuloma is concerned, there would be, depending on the size, although you can have some small early granulomas without, but there would be some evidence of intraocular inflammation, maybe some vitreous cells. The fluid would be out of proportion, because if the granuloma is active to the size of the lesion, so a very small granuloma, extramacular, could have pretty low vision because the fluid could be seeping into the macula. And of course, the angiogram would be characteristic. And ma'am showed excellent images of one of those choroidal granuloma patients, the OCT showing predominantly loss of architecture of the choroidals, like a featureless thickened choroid with overlying secondary changes in the retina. So the OCT for choroidal granuloma and the ultrasound, if we were to just narrow it down to one, to differentiate an osteoma from a hemangioma.
I think it's very interesting topic. Probably we'll take more of it during discussion. Thank you, Rima, for a wonderful presentation.
Thank you, ma'am.
Yes, I would love to introduce Mohit. Mohit is young star with us who's going to talk about large subretinal bleeds, tricks to manage. He loves managing these subretinal bleeds.
Thank you, ma'am. Thank you for the very kind invite and the maverick kind of introduction that you gave me. So thank you, ma'am. I think. Is my screen visible?
All good, all good.
Great. Thank you once again. So I'm just going to talk about large subretinal bleeds and change tracks a bit and get into some surgical retina. So just etiology. Just this is not going to be a didactic kind of a sermon, but you have your usual suspects. So secondary to neovascular AMD, PCV. It could be a ruptured retinal artery macroaneurysm, could be secondary to trauma, valsalva retinopathy, rarely blood dyscrasias in which you might have multi-layered hemorrhages, and or sometimes tumors. Melanomas can present if they are posterior, and certain other ones might with secondary membranes, very rare but may present. So I'm just going to present two quick cases with two surgical videos with them, and then have one slide at the end which it might be the take home, and then I'm going to call it quits. So 48-year-old hypertensive male actually presented with vision loss, and that's the picture that the patient had. So vision was hand motions. You can see you can hardly make out any of the macula or the extramacular region. The yellow arrow actually shows you the sub-ILM component of the bleed, the multi-layered hemorrhage. The red one, because you can see those blood vessels going over it, or at least you will be able to see them in the surgical video, shows the subretinal component. So we didn't know how much it was extending the subretinal component below it, but we knew it was considerable and was involving more than the macula. So we took this patient up for surgery, standard 25 gauge setup, as is usually done. And this is typically, so we were able to get the image of the patient. The image was taken 2 days prior to surgery. And by the time we wheeled the patient in for surgery, the patient had actually bled through and had a breakthrough vitreous hemorrhage. Because had the patient come like that, we would not have been able to get that photo. So just showing, after you clear the hemorrhage. So that is the intra-op, appearance. That is the sub-ILM component, and that large, dark colored, non-red looking is the retinal blood. Quickly, these are the easier, if I can say, if I can use that term, cavities in the retina to evacuate blood out of. So after the sub-ILM space, blood is gone. That's the site of the ruptured retinal artery macroaneurysm, which was visible. And you can see that's the subretinal cannula. I would just quickly like to show you the setup here. So I entered, I've just paused the video. I entered with a 38 gauge Med1 cannula, which is mated to a 25 gauge back end. So it can go in through a 25 gauge cannula. And there are different schools of thought how to inject things in the subretinal space. I like to take control myself, and that's why I like to go in bimanually. Hence, as you can see in the setup, a fourth port at 12 o'clock has been introduced for the chandelier illumination, and to have my other hand free. And also, I like to deturgest the vitreous cavity, because I would be injecting fluid under the retina. The machine, the Constellation machine, which we use at our center, would not be able to compensate for the increase in volume in the subretinal space. So although you can reduce the intraocular pressure a bit, but a vent ensures that there is constant efflux. And once you inject in the subretinal space, and if you inject yourself, which I like to do, and not let my assistant inject, it's actually safer, as we will see. So so that's the tip of the cannula, and just inferior to the superior. I've actually not edited this part. This is real time. It's not difficult to enter. It's a very sharp cannula. It's a very sharp, albeit non-metallic cannula. Now the air which is entering here is inadvertent at this point in time, and that's because the cannula is attached to a 2 cc syringe, which has 0.4 ml of balanced salt solution and 0.3 ml of filtered air. And once you inject it, because of gravity, the fluid will go down. So you will be able to inject fluid first, and the same needle. And you can see once I'm injecting, the relatively flatter, darker looking blood is now, the retina is actually ballooned up. And I proceed to inject the entire 0.4 cc of fluid, and now you can see I've made it into a bullous, detachment, as can be seen in that wide field photo. And in that wide field image. And now I go back, try and re-enter through the same site, and go on to inject what looks like a million fish eggs. And unlike pneumatic retinopexy, getting multiple fish eggs here is A, not detrimental, and B, I don't think you can do anything about it. You can't shake it. So it's not a cause for worry. So that's what the patient had at that point in time. And that is pretty much the end of surgery with just fluid air exchange being the step which is left, as you will see. And that is a critical step because you want to force all of the bubbles will tend to move to the periphery wherever there is the large bleed. So once you do the fluid air exchange, as you'll see, again, this is just about 25 seconds to go. You will see, because of the pressure of the air, all of the fluid will be pushed back into the macula. You will see it approach like a tsunami wave from the temporal edge now. And this is very slowly, because all of the fluid injected in the subretinal space is being pushed back towards the macula, and that's what you want. You want the fluid and the blood to kind of intermingle. And after about a 70% fluid air exchange, that's the end of the picture. That's the end of the surgery, the photo at the end of the surgery. And I like to suture all my ports, left the patient with partial, about 70% fluid air exchange, no gas, and gave the patient heads up position. So this is what the patient had. Now, one thing which must be kept in mind is you've made an opening. You've seen that the blood is mobile. There will be, and you should expect some loose blood, considerable amount of loose blood, not only in the vitreous cavity, but also you can have, depending on how much blood there was. Now, this was decent blood, but not a lot. But even in phakic young individuals, you can get hyphema for 2, 3, 4, 5 days post-surgery. Should not be alarming. The loose blood could last up to 2 to 3 weeks. Now this patient's done pretty well. This is the same eye, 618 parts. That's a iatrogenic break I had. I have lasered. Sorry for the decentered autofluorescence, and is almost near normal restoration of the foveal contour. I'm just going to go to the extreme second end, a larger hemorrhage. So this is a PCV. You can see the quantum of blood is even more, and the steps of surgery remain same. I have purposely omitted hyaloid removal in those steps for the interest of time. So, but otherwise, that's what we would do. You can see that this hemorrhage, the patient has scarring in the center and more extensive blood, which is actually extended past the equator inferiorly. So, Canacort assisted hyaloid removal. I'm just going to skip that. And so that's the setup I was talking about. Enter with the for the fourth port, and inject. Yeah. After I enter with the cannula there, inject my subretinal cocktail. As you will see now, and this is just after, and you will see the air bubbles actually migrate real time inferiorly. So they tend to move to the area where a plane has been created either by the blood or with the previous bleeding. But after fluid air exchange, that's what you do. You get the air bubbles in the periphery. You do fluid air exchange. You force the fluid back, and that's the kind of resolution that you could get. So massive hemorrhages like that, no big retinotomies, no giant tears, nothing that I'm doing. And that's the last slide. If there's one thing that one should consider while attempting these surgeries is the size. So small is less than 4 disc diameters. If the patient has no orthopedic issues, you can safely avoid surgery and just try pneumatic displacement. Large is more than 4 disc diameters up to the equator, like both of my cases. And total, could either be with retinal detachment, or when you can't make out anything what's happening. Please be very, very, very guarded when you're offering surgery for these eyes. The duration is very important. I think we all know the earlier the better, but whatever published data on this, it says that within the week that has the best prognosis. Anything above 14, reconsider surgery. And if it's more than 21 days or the blood is yellow, please don't offer surgery, would be my indication. Something that is not talked about as often, but is important, and we've learned this from our Japanese colleagues, is the thickness. And this is based on the OCT. This is the thickness of the subretinal blood. So if the thickness of the blood is equal to or more than the thickness of the retina, then that means it needs displacement, with most likely with surgery. If it's thinner, then just pneumatic displacement would work. And then etiology, I've already shown good and bad prognosis cases. Both my cases, the anatomic outcome was pretty good, but the functional outcome depends on the underlying anatomy. The RAM case had very good vision, 618. The PCV case, more extensive hemorrhage, had pretty good anatomic resolution, but the underlying disease precluded great vision, and the patient was left at 2.5 meters only. So thank you. Thank you.
Thank you, Mohit. That was a very clear-cut message that the cases should be referred at the earliest, because a lot can be done for them, and probably without delay they should be intervened. Dr. George and Dr. Atul, would you like to comment, please?
It's very good surgery. I do quite the same. The only thing I used to inject TPA when you got this huge subretinal hemorrhage, and should not exceed 50 micrograms, because after that's going to be toxic for the retina. And sometimes at the end of the surgery, I inject anti-VEGF when you have PCV or neovascular membrane. And I don't use large subretinal bubble. I just use more fluid in subretinal space and do only half fluid air exchange like you did. And sometimes I use SF6, but I agree that air is very good. And I love your surgery. Beautiful. Thank you very much.
Thank you, sir. Thank you. Thank you.
Mohit, at the same excellent lecture. We really enjoyed your videos, as always. So I was just wondering, because a recombinant TPA, I generally try to use about 12.5 micrograms in 0.1 ml. So I use 0.2 ml, and I use Avastin, which is about 0.1 ml, which is equivalent to about 0.1 milligram, and I inject air, the cocktail of these three. So I was just wondering, without TPA, do you think the clot lysis will occur?
Yes, sir, absolutely. So we actually, sir, have an ongoing thesis with one of our MCH candidates in which we have prospectively looked at randomizing patients with large subretinal hemorrhages. One is to subretinal TPA with air, the other is to subretinal BSS with air. I showed both of these cases, sir, with BSS, and I can't speak too much more about that at this point in time, sir. But it seems to work, sir. It seems to work, sir. It seems.
Yeah, because surgeries are splendid, and the post-op results were outstanding.
Thank you, sir. Thank you. Thank you, sir.
Yeah. With this, I would like to invite Dr. Anirudh Agarwal, who's a part of our team and a dream student who's recently joined Cleveland, Abu Dhabi. And Anirudh is going to tell us about, it looks like AMD and it's not. It's extremely important to avoid unnecessary injections. Over to you, Anirudh.
Very good afternoon, ma'am, and thank you very much for the invitation and for making me a part of this session. So I'm going to be talking about very few simple cases of AMD. So are my slides visible? Everything okay?
Yes, all good.
Thank you. So my first case is a usual case of age-related macular degeneration that you see in our clinics. And this is a 73-year-old male, Caucasian, has had 3 previous injections elsewhere. And the visual acuity is poor in the left eye especially, but also low in the right eye. And if you have a look at both the eyes, you have this grayish membrane in the center. And the left eye has hemorrhage right in the macular center. And if you look at the OCT, it's very simple. There's nothing much to be discussed. There is a double layer sign in the right eye, and the left eye has intraretinal fluid, subretinal fluid, and a CNV. So this looks very much like a straightforward case of AMD. And if you see the fluorescein angiography, it shows you the early hyperfluorescence, especially in the left eye. You can see that there is this membrane which is lighting up in the very initial phase. And as you progress, you have this tripled hyperfluorescence, which is coming in the late phase. So far, so good. So this is AMD, right? But the diagnosis, of course, here is a bilateral CNV. And if you look at the ICG, what do you see? So on the ICG, actually, you're able to see very distinct areas of hypofluorescence in both the eyes, which suggest choriocapillaries hypoperfusion. So what is this exactly? These are nothing but choroidal granulomas. The lesions are highly suspicious for granulomas, and this patient was investigated, and this patient actually had a quantiferon positive. CT scan was positive, and this patient had actually a sputum culture positive for TB. And if you see the 4-month follow-up after treatment with steroids and antitubercular therapy, the ICGA looks much better. This patient, of course, went on to receive injections for the CNV, which was secondary to inflammation. So this is very important for us to realize. And if you go back to the clinical photo, you will realize that in patients who do not have any other feature, apart from the neovascularization, this patient doesn't have any drusen. And that's a very important feature that you see in this patient, which should sort of make you aware that this could be an alternative diagnosis. So the first and the most important condition which mimics AMD always is an underlying posterior uveitis. Let's look at another case. This is a 65-year-old female Asian Indian, has visual acuity of 20/80, diagnosed with wet AMD. And of course, you can see this pre-retinal hemorrhage and this yellowish grayish membrane in the retina. Now, if you look at the fluorescein, it's very important to see that the fluorescein shows you what the ICG may show you, but even the fluorescein can be sometimes enough to show you this kind of the polypoidal lesions on the angiogram. So when you are in the clinics and when you are in a hurry, you may actually miss these polyps, and a blown up image very clearly shows you these polyps which are seen on fluorescein angiography. And of course, ICG will very clearly show you these polyps much better than the fluorescein angiography. And this patient has additional OCT features which are not very typical of AMD. And this is something which is very important for all of us to realize, that when you have this sort of a PED and you have subretinal fluid, peak PEDs, and this double layer sign, this is a PCV, and this must be differentiated from the usual garden variety of AMD. And now we have the non-ICGA OCT features which have been described that have a very high predictive value of PCV. And these include sharp peak PEDs. Especially I look at the double layer sign, and I of course look at the other features such as the NFAS OCT complex RP elevation, which is something that you see as a hyperreflective branching network which are connecting multiple PEDs. So there is a multiple sort of a multi-layered PED and multiple PEDs which are seen. These are very important features of PCV. Let's look at another case of, this is a 68-year-old male, has this kind of an appearance on the OCT. Now, if you look at this picture, you should never miss the choroid. Such a thick choroid, and you have this double layer sign. This is definitely a pointer which is against age-related macular degeneration. And if you look at the ICG, it shows you this diffuse fuzziness and haze, and you have prominent vessels. And nowadays, we are also looking at the vortex veins for the engorgement of the vortex veins. And this definitely goes in favor of pachychoroid neovasculopathy. So always look at the choroid. In patients with AMD, we expect to have a thin choroid because of the disease itself, as well as the age of these patients. And so looking at an alternative diagnosis such as PNV is very essential. And we have another patient here who has decreased vision in both the eyes and metamorphopsia. And you see there are drusens now. So you can't argue that there are no drusens in this patient. And if you look at the fluorescein and ICG, on the fluorescein angiography, the drusens light up very well, and the ICG shows them as hypospots. This is in the late phase, and this is the other eye which shows you these drusen. Now, this patient on the OCT has subretinal fluid and large colloid drusen. Now, remember, this is a patient who, when you perform OCT angiography, does not show you any neovascular network. So what is this? This is a case which we have published in the past, and this is a patient with early onset drusen. Now, these patients with early onset drusen, especially colloid drusen and cuticular drusen, may have this kind of an optically clear space on the OCT, without a neovascularization, and you can check it using OCT angiography. Even in fact, the fluorescein angiography doesn't show you much leakage. And so these patients may have no neovascularization, and simply the colloid may exude and create an optically empty space. Very rarely, you may have very small micro neovascularization, which may not be picked up even on the OCT angiography. So it's very important to follow up these patients. But this patient definitely did not have any, and this patient does not require any treatment. My last case is that of an elderly male with recently diagnosed metamorphosis in the left eye, and this is how his OCT looks like. And so again, you have this double layer sign, you have sort of a optically empty space, and which looks like fluid. And this patient has hyperfluorescence on the fluorescein angiography. But if you look at the late phase, and if you look at the autofluorescence, actually, this is the autofluorescence image which shows you hyperautofluorescence. This is something which should be an important feature that should remind you of vitelliform disease. So if you look at this patient has a prolonged history from 2012, and this patient always had this kind of vitelliform lesion right under the foveal center. And with time, the vitelliform material actually absorbed. And so this is very important for us to realize that these patients do not require anti-VEGF therapy. So what can you commonly misdiagnose as AMD? It should be PNV, PCV, uveitis, early onset drusen, and adult vitelliform disease. Of course, we have more conditions which can mimic AMD, but I'm going to limit my talk to these conditions because of lack of time. With this, thank you very much, and I'll be happy to take any questions. Thank you.
Thank you, Anirudh, for the wonderful presentation. And before I go on to mine, I would ask Dr. Diksha and Dr. Rima to please comment as to how commonly are they seeing the entities that Anirudh is so beautifully mentioned? Is Dr. Diksha there?
Yes, ma'am. Yes, ma'am. And the vitelliform lesions, yes, we are seeing, and these are the ones which are commonly misdiagnosed and even treated sometimes. Sometimes they have come with, they have already received multiple injections of anti-VEGF after a diagnosis of AMD. Secondly, the uveitis and those conditions which are associated with uveitis, those are also seen. The pachychoroid spectrum, ma'am, we are just recently beginning to actually look at. So I have initial experience only as far as those entities are concerned. But yes, vitelliform and uveitis, definitely, ma'am.
Rima, would you like to add?
I missed because I was presenting my talk in the other session. Can I have the...
Okay, we go back to the next. The question is CNVM. How frequent is it for you that they were diagnosed as AMD, but they had subtle few dots suggestive of posterior uveitis? And when would you do ICG to rule out those dots or to look for posterior uveitis in AMD patient? No drusen.
No drusen. And diagnosed as AMD. Okay. I think, ma'am, I'll first do an OCT angio, and fluorescein will give a lot of clues, and I would prefer to do a fluorescein in ICG, of course. So, but if it is...
So I think whenever, ICG would give the answer. So whenever in doubt, go for it.
I would go for a combined.
I agree. So there's a question which I would like to ask all of the panelists before I move on to my last talk. And that is the question that if you have biomarkers on OCT, diabetic macular edema, that show you poor prognosis, would you still go ahead with pars plana vitrectomy for recalcitrant cases or for tractional kind of detachment? We start with Professor Atul Kumar.
Well, it depends what kind of biomarkers are there. If they are very poor prognosis biomarkers like the discontinuity of the ellipsoid band, which I give a lot of weightage to, and there's presence of a lot of ORT, and the retina is thin, the macula is thin in the center with total, loss of architecture. Such cases probably I would defer. If the macula is thin, it's less than 250 microns in the central subfield thickness. I'd rather tell the patient that we'll get you a good refraction and injections may not help and we won't do surgery also.
Yeah.
So it's important to explain it to the patient.
Dr. Georgie, would you do anything different?
No, I do the same. I just think that even with bad biomarkers for improved visual acuity, you should treat this patient because you can stop the process in stable the vision. If you leave the patients with the traction, they probably gonna get worse in macular atrophy.
Anirudh?
Ma'am, I think if there are outer retinal signs such as ellipsoid zone dysfunction or ellipsoid zone disruption, which is away from the center, then I think definitely yes, we should give the potential to the eye. We should try and operate. But again, if it's center involving and there is too much of fibrosis or if there is severe loss of photoreceptors, then defer until we reach a stage where the patient has either is monoocular or is dependent on that eye or has a requirement. So I think it depends on the requirements of the patient. So it will involve a lot of counseling and discussion with the patient.
Ema?
Yeah, ma'am. Well, I would do a fluorescein to check for macular ischemia. If it is there, then I think I would counsel the patient that surgery would not help. And unless there is neovascularization, like a taut posterior hyaloid, to stop the progression, then only the surgery would be required. But after taking the patient into complete counseling.
Diksha?
Ma'am, I agree to what others have said. Like if the presenting visual acuity is very poor, less than 660, like counting finger vision, you have a thinned out retina, or in fact you even have sometimes very large cysts with very thin septae, and there's a loss of the ellipsoid zone. The outer retinal architecture is disturbed. And coupled with that, sometimes in Octa can show if there is a macular, how is the foveal vascular zone looking like. So if that is also showing ischemia, then we'll not operate such a patient. We'll just counsel him because unlikely that the vision is going to improve.
Mohit, would you like to add anything?
I would just like to say one thing that I'd like to, I'm a non-operator for non-tractional DME, irrespective of OCT signs. OCT is good, bad, ugly. I will not operate for non-tractional DME. I'd like to keep my practice a little simpler than that. I don't operate for non-tractional DME.
Fractional variety, but very poor prognosis. Would you remove
If it's the only eye, ma'am, irrespective of OCT parameters, I would do it. If it's not the only eye and it's tractional DME, then all of what ma'am, you, sir, and everybody said. But that's the only subset. For non-tractional DME, irrespective of OCT signs, I would not operate, ma'am.
So Dr. Surinder, you asked this question. I think by and large it is customizable, but most of the panelists agree that unless you are really pushed to wall, they might hold on. So with this, I would present the last talk of this session, and I would request Rima to take over the role of moderator for me. So this is the subretinal lesions. Beware of masquerades. You heard about beautiful choroid from Diksha, and you heard about subretinal hemorrhages from Mohit, and about pachychoroid, and everything was Rima covered choroid, and Anirudh covered AMD and what lesions. But what about this subretinal space? Subretinal space is the kind of the space which is nasty. So if you are seeing anything which is neither retinal nor choroidal, be very extremely aware. Now, this is an 8-year-old boy who comes decreased vision and some history of fever, cough, malaise, and you can clearly see the lesion is in the subretinal space, bilateral. So what is unusual? It is a whitish color subretinal lesions, and it looks more like something has been deposited there rather than something which is pushing, like Rima showed those granulomas which were pushing it forward, or Mohit showed that blood. So it looks neither of that. So what it could be? Any situation like this, always think of masquerades. So that is what we thought of. Peripheral blood smear showed acute lymphocytic anemia, leukemia, for which the patient was subsequently treated. So leukemic infiltrates in the retina generally have large gray-white nodules, which could be variable size, or you could have grayish-white streaks along the vessels, which may be caused by the local perivascular leukemic infiltrates. There may be optic nerve head infiltration or frosted branch, though not so common. The second thing is sometimes the patient comes with floaters, which may not always be benign. For example, this lady came, and to be very honest with you, we did not see any lesions. There was some vitritis, but because the subretinal lesions always may not be on your face, like I showed you in the last case, but try to look for them. The fluorescein shows this pattern, which is not a good pattern if you ever see one. Do the autofluorescence, do the OCT, do multiple scans, periphery. If you are seeing these lesions, which are typical subretinal deposits, which may be very early sign of primary vitreoretinal lymphomas. So we did have suspicion of lymphoma based on her age and based on the OCT findings in autofluorescence. However, patient was asymptomatic and she did not want to undergo diagnostic vitrectomy. 3 months later, the MRI, which was normal when we did it, 3 months later, she now shows hyperintensity in the deep, this thing, and it's something which is suggestive of lymphoma. So neurology was inconclusive. I'm not going to go into the long story, but what I'm going to show is that this patient eventually came out to be lymphoma. Diagnosis clinched by observing a single lymphoblastic cell in the dividing phase. So don't get discouraged that you have done a vitrectomy and it doesn't show cytology positive, because it's very difficult to look for even one single cell. So what you should be doing for, looking for IL-6-10 ratio, because IL-10 will be highly elevated in lymphoma. It will help in differentiating. And mid-88, that is the gene. If mid-88 is positive from vitreous, even though the cytology is negative, you should always think about lymphoma. This patient kind of worsened a lot. She responded to methotrexate rituximab combination that we gave, but she had a very turbulent course over a period of time, which I'm not showing, but we published it in Retina as diagnostic and therapeutic challenges. But it all began with one small subretinal lesion. So you could be the first one to identify that lesion and increase the life expectancy of these patients by looking for CNS lymphomas and treating the lesions in the brain in coordination with your team. Please remember, if you see subretinal deposits like that, which on OCT show the deposit under the RPE, always go in for vitreous biopsy, no hesitation. Only important thing is your cytologist should be very competent and should be ready to receive the sample and do it in a proper way. Always do the MRI, even if it is initially normal. It's important to follow these patients over a period of time so as not to miss the life-threatening pathology. OCT biomarkers, again, we published with Anirudh that it's very important to look for some of these signs, because a picture like this, you may be confused with toxoplasmosis, viral, or lymphoma. So if you're having the double roof configuration on OCT, if you're seeing hyperreflective disorganization of the layers, subretinal and sub-RPE infiltrates like these arrowheads here, always think of lymphoma. Just go and take the sample out. And while taking the sample out, it's very important, do not always chase, because I'm a vitreoretina surgeon, so we have a tendency to chase the clump where the cells are clumped together. Just remember, lymphoma cells are malignant cells. They will not adhere to each other. So that clump which you are chasing may be most likely inflammatory. So always get the sample from various areas, even the clear vitreous, because that is what might give you actually the diagnosis. My last case, something which doesn't seem right. This is with Bill Mailer. You see this patient, it came like VKH, but why should a VKH patient have these lesions? So the patient, the fluorescein is not really typical of VKH, but it's not atypical also. So if it was today's era, I would do OCT and basilarity layer detachment, but important to look at the history. The history patient did have multiple signs of retinopathy, and his previous bone marrow biopsy was non-diagnostic, though they were suspicious of lymphoma. But when you have this kind of presentation in the eye, don't give up. Keep on chasing your internist friend, your oncologist, or whatever the patient is under. And finally, he was diagnosed as hemophagocytic syndrome. So, in conclusion, subretinal deposits, something which does not look very right to me, right to you, or something which appears unusual, always think of masquerades. Thank you very much. So I think we still have time for discussion. So
yeah.
We can take some questions. Hello?
Yeah, ma'am. I think there's some internet problem. Some connection is breaking. Can you hear me, ma'am?
I think it's my end. Yeah, I can hear you.
Okay.
So, Dr. Georgie, do you have any experience with masquerades?
I love your case, but we don't have a lot of masquerade syndrome like you shown us with lymphoma or leukemia. I don't have experience in such neoplasies here in Brazil. We have very few cases. I don't see it very frequently.
Can I ask a question?
Anirudh? Yeah,
Yes.
sure. Go ahead.
Ma'am, here we're seeing a lot of patients with leukemia, and they have white-centered hemorrhages, but not so much of the subretinal deposits. So I think when there are subretinal deposits, probably it's easier to diagnose, but there are lots of patients who have just the hemorrhages in the retina, but no deposits. So how do you approach such a case? What would you?
For venous congestion, if the veins are dilated, that could be another very important marker towards leukemia. And if you can do, we published in ophthalmology retina that sign of 8, but
Yes.
that was only one patient. So probably now that you have a series of patients, it might be a good idea to, validate that sign, because if the viscosity within the blood vessel is changed in leukemia and you can pick it up on OCT, that would be a very interesting sign to validate. Yes. Diksha, would you like to add anything? You're muted, Diksha.
No, ma'am.
Dr. So before we conclude, let's one important carry-home message from each of the to our attendees. You are muted, sir.
Sorry, I could not hear you. I have an internet problem. You asked to have a message from the talk. Is that?
One line concluding remark from your talk.
The biomarkers is very important to predict treatment and progression of the disease. And OCT, B or A, it's very important in your practice. When you see prediction that we lose the photoreceptor, like the ellipsoids line or steroid-limitant membrane line. This is very important to counseling the patient. That's even with the best treatment that we have, sometimes it could not improve vision. And this is very important nowadays. We have all the tools that can predict treatment and if the patient go for good vision or not. Thank you.
Thank you, Professor Atul.
Yeah, non-responding DME or recalcitrant DME, it's important to check for peripheral ischemia in the white field, or the spectralis also is 102-degree FA. So you got to look for ischemia. If this there, you got to laser it. Second, look for the changes of biomarkers, and those biomarkers show things like WART and degenerative macula. Then those cases, or with drill and all, don't have a very good poor prognosis. Have usually a poor prognosis. So you have to explain them. Check for good control of diabetes and blood pressure, as well as lipids, and those are the things which are very important. And only if there's tractional DME do you resort to surgery.
Thank you, Dr. Rima.
Yeah, ma'am. Choroidal lesion, I think first and most important is clinical clues. So once we examine the lesion, we look for every sign around it in the fundus, and then we choose the imaging modality accordingly. So we go from non-invasive OCT to OCT angio if required, and ultrasound of course helps a lot if we have challenges in terms of osteoma or hemangioma or a mass lesion.
Yeah, just 1 more minute we'll take. Don't on so much. Dr. Diksha.
Ma'am, I just like to say that as ophthalmologists, as our understanding of disease pathologies are improving, we need to be aware of these newer entities which are coming up, and we need to look for them. And probably once we understand that what are the causes of the hyperpermeability, probably it is systemic, probably it is a local pathology which we haven't understood, but maybe that we may evolve into disease or treatments which can help reduce choroidal thickness, and PDT and other such things and micropulse lasers may be of benefit. So we need to know about these entities.
Anirudh, you are the last one.
Yes. So I think whenever you have a patient with AMD, which looks like AMD, but you don't have typical features such as drusen and RPE changes, always think about alternative diagnosis, especially vitelliform disease. It's very common, and always look at the autofluorescence at least once during the course of the disease, and not just treat the patient based on OCT alone. Thank you, ma'am.
This, I would like to thank my team at PGI, a superb team, and Dr. Atul, who's a part of PGI to us. And
thank you, ma'am.
our guest speaker, Dr. Georgia, it was a wonderful session. Thank you, everyone.
Thank you.
Thank you so much. I thank all the speakers for the wonderful presentation, and Dr. Vishali Gupta ma'am for leading this session wonderfully. Thank you so much. By this, we come to the end of the session. Stay safe.
Thank you.
Thank you.